Good evening to Respiratory 241. It's week 4. It's October 23rd, 2017. I'm your instructor, Tim Dunkle. And welcome to week 4 live lecture. Um, it's been a great mod with all of you. I appreciate everybody's efforts and your hard work and your attentiveness and your comments and your work on your assignments and your assessments and everything in between. I've enjoyed working with you, and it's been a great mod. I hope that all of you are in a position where you're comfortable to move on to your next ventilator course. And if you have any questions this week, I'll say it probably lots of times tonight. If not, let me know. Call and leave me a message or text me or email me, whatever you want to do. Please feel free to. Had some concerns that my email link wasn't working, and I checked it a couple of times just as I was getting ready for this. And on my end, it's looking good. And I had another person check it, and it's operating. So we had a hiccup with one student, so I apologize for that. But everything looks like it's jiving on my end. So text me or call and leave a message. I will get back to you through those outlets. I might not get back to you immediately over the phone, as was today. I had a couple of critical vent admits in the ICU I was working in today, and but I'll get to you as soon as I can. I'll either text you or call you back when I get off shift. So anyway, if you have any problems, let me know. I'm happy to do whatever to help you. So with that, let's just run down just a couple things I wanted to review. This week's assignment and last week's assignment. Overall, good job on your calculations with your compliance and talking about vent strategy for ARDS, etc. Good citations and that sort of thing. If you didn't or had issues with the calculations, I let you know, and know that you can recalculate those and just resubmit them to me or email them to me or whatever, and we'll get you your points. No big deal, but make sure that if you're having issues with the calculation, let me know. I went over how to calculate that in last week's lecture because I had a student specifically ask me about that. So we went over that. So if you don't get it or having any issues let me know, and we'll work with you either on the phone or open up a Zoom chat like this, and we'll get it taken care of so that you understand. But overall, good job on the assignments and last week's discussion. I was happy with everybody's, for the most part, everybody to get a really good job on your papers. And wrapping up this week, I think we'll just see more of the good from you. Everybody's done a nice job working on their assignments. So for this week, we continue on with discussing ventilation in the assignment. And this week we're going to give you a patient that gets sick, and you're going to have to react to that patient and make decisions and justify your decisions and what settings and so forth with that. So that's going to be a good assignment for you. So make sure you're ready for that. I think you'll enjoy that. And then for the discussion this week, I always like the lead up to discussions, all that information prior to the prompt. And this week's prompt for our discussions is talking about ARDS. So go ahead and make sure you read through all that, and look forward to your posts on that. The reading is chapter 12 and 13 this week. There is portions of the reading in the final. The final is from the entire mod, so make sure you're ready on that. So if you've looked at your quizzes and you've reviewed your quizzes, you should do very well in the final. I'm going to review some stuff as well tonight on final. Remember, this final is an honor lock final. I've had patients, not patients, that's still the mode I'm in. I haven't been in the ICU all today. I've had students that have had issues with honor lock. They've either talked to people or they've had stuff out or whatever is going on. If you have one of those critical issues, then we issue you a final 0 and issue a warning that if it happens again, then we can dismiss you from the program. So don't do that. Just have your follow the rules and do what it says, and you'll be fine. So if you have any questions before you take the final, let me know with honor lock, but I don't anticipate any issues. But please just follow the rules and you won't have any issues. Like I say, it's been a pleasure to work with you as all of you are continuing on, and you're the future of the business. Just keep working hard. The TMC is your ultimate goal. You've got to take that to work in the business, and you've got to pass it, and it requires work, and it takes a lot of preparation and a lot of hard work to get ready for that. And there are a lot of resources through IU that will make that happen for you, but you got to take advantage of them, and you got to focus on that every single day. That's your final goal. So you're the future RTs, and it's been an honor and pleasure working with you. I'm sure I'll see you in other mods, etc. I teach some other clinical courses and that sort of thing. So, but know that you can contact me down the road as well, that I don't have to be your instructor for this particular mod. For you to contact me, that you can use me as a resource in the business, and whatever I can do to help you with that TMC exam, I am happy to do so. So please get a hold of me in the future, and so I can help you out. So we talk about, now let's jump into the final review and just go over some things that you should be know, and hopefully when I throw out these words that you think, oh yeah, I remember that, or I can speak to that. If you can't, then spend some time on it and get to know these things and review your chapters, and you'll do just fine. So remember, week 1 we started talking about negative pressure ventilation versus positive pressure ventilation, the iron lung, the parts of the ventilator, and what that entailed, the breath delivery unit, the user interface, the circuit. There's a couple of different types of circuits out there. We talked about positive pressure ventilation, different ways that the breath's delivered, that we could have a piston or a solenoid or a bellows, or several different ways to deliver that breath. And so it's important that you understand all of those. And then we took you into the different pressures. We talked about alveolar pressure and thoracic pressure and transairway pressure, and showed you a graphic that summed up the different pressures that we're dealing with atmospheric pressure, and in a positive pressure breath, what that pressure change looks like versus a negative pressure breath, and a spontaneous regular breath, and know what those pressures are doing. Um, we talked a lot about, throughout the entire mod, we talked a lot about compliance and resistance. Remember that we have to overcome the resistance of the airway to get gas to ventilate the alveoli. And so that's important that we have enough driving pressure, because that's our ultimate goal, that we have internal and external respiration. And so we need to account for that when we're positive pressure ventilating someone. And then compliance and the calculation of the dynamic versus the static compliance, and what that means. And remember that the higher the better. That if we have high tidal volumes and low pressures, then that's going to give me a bigger number. That typically we say, 50 to 100 is kind of quote unquote a normal range. And the lower the number we get, then the stiffer that lung is, because that tells us that it's a higher pressure for a lower tidal volume. And before you even calculate that, you can see that relationship. That if I have high peak airway pressures or high plateau pressures and low tidal volumes, then we know that potentially that compliance number is going to be low. We talked about indications for ventilation. We talked about not only, from an assessment and physiological standpoint, but we also in order to in order to begin ventilation, that we have some possible ethical issues to deal with. Is that patient ever going to get better? Are they going to benefit from them? Is it something that is going to, help them to recover? Things of that nature. Is it ever their wish for them to go on? Things of that nature that we need to look at. So when we start thinking about indications for ventilation, make sure that we make an accounting for that from that side of it. But then also, yes, we have our indications, whether it's hypercapnic respiratory failure or hypoxic respiratory failure, and make sure that you can differentiate between both of those. And it could be both of them combined. And keep that in mind, that when we identify those, that that's the indication that we're going to put on. Perhaps it's just that they can't maintain their airway, that's a post-op patient, or they've been intubated for some other reason, and that can be an indication for ventilation as well, that they just aren't awake and can't protect their airway. So make sure that you're comfortable with all those. And that leads into our next little thought is non-invasive ventilation. When can we get away with non-invasive ventilation? What are the indications that what are the indications for non-invasive ventilation? Remember, if they're spontaneously breathing, that they're tolerating it, that they're awake, things of that nature, that maybe we can try them on non-invasive ventilation. But on the flip side, that if they're not conscious, they're not protecting their airway, they're not spontaneously breathing, things of that nature are obviously going to be contraindications. Also, if they cannot tolerate the mask and things of that nature. As far as initial setup, remember we talked about for an initial setup to calculate the ideal body weight for your patient. And then with that ideal body weight, that we're going to take 6 to 8 cc's per kilo of ideal body weight. And that's our initial tidal volume, that we set our rate, set our PEEP, set our FiO2, and we set our vent to get running. And then we set our trigger and we check our alarms and all of that. And once that gets up and running, then we're going to draw blood gas 30 minutes to 60 minutes and then make any changes that we need at that point. As a part of that, next step down is modes versus breath types. Make sure that you can speak to the ventilator, the various ventilator modes that we have, and the breath types underneath those modes. So when I talk about assist control, or CMV, AC CMV, we have 2 breath types that mode can provide. We can provide pressure control, or we can control volume control. So those are the limiters of that mode, and within that breath type, that's when the vent knows when to terminate that breath, is when it's hit that target pressure or that target volume. And all the pluses and minuses of both of those. Also within that is, remember, we have patient triggering. We have machine triggering and patient triggering. If the patient trigger is pressure or flow, and that you can differentiate between that. We also have SIMV as a mode, which also has pressure versus volume-based breaths. And keep in mind that the mandatory breath in SIMV is going to be a control type breath, where it's going to do the whole breath cycle, but the spontaneous breath is more of a spontaneous breath with some pressure support, and the patient does the whole breath cycle, which leads us to the last mode, which is spontaneous. That leads us next to our strategy. What kind of strategy are we dealing with? Are we dealing with COPD or asthmatic, where we have obstructive type lung issues, where we need high flows or low I times, so we have a long E time, versus ARDS, where we want to change our tidal volume from 4 to 6 cc's per kilo to 4 to 6 cc's per kilo as more a lung protection strategy, and we're going to run higher PEEPs and longer I times for a higher mean airway pressure, versus, you know, a trauma patient or a brain injury patient, where we're going to run lower PEEPs so we get good venous return and we're not backing blood up into the brain. So keep in mind that there's going to be some of those strategies there. Overall management. Make sure that the management of the ventilator, that we're checking alarm settings and accounting for what our alarms are before we put that patient on, and our other checklists before we put the patient on the ventilator, that we have a BVM or a back valve mask present, and that we have the right interface, and we've confirmed tube placement, and all of that's lined up ready to go when we place them on the ventilator, and then we draw initial gas 30 to 60 minutes after that, and then subsequent follow-up gases as needed, so that make sure that we're keeping that in mind. The calculations, we talked about that a little bit earlier. Just remember that you need to calculate ideal body weight. Make sure you calculate your target tidal volume from that. Make sure that you can calculate your airway resistance, your compliances, those types of calculations that you can see on the exam. And then we touched on earlier the internal versus external respiration. So if you have any questions before you take your final, please let me know. Just keep in mind that honor lock is a part of that, and so you need to make an accounting of that. So let me know before you take that if you have any issues. It wasn't unlocked today. I had a student that wanted to take it. That is now, I checked with Tammy Alsop, and she jumped in and everything's unlocked, so it should be good to go for you. So let me know if you have any issues with honor lock when you jump in. So let's jump into our final two chapters of the mod. This stuff will be on the final exam as well. So I do want to still jump in and cover that so that you are aware and know the material as you prepare for your final exam, so that you'll have that as well. So first is chapter 12, and we're going to talk about more patient ventilator management and get into some of those things that entail that. We obtain our sample after we've established the need for ventilation and place them on, and then we need to make some determinations of how to correct those abnormalities. Perhaps the most common calculation that as RTs that we probably use when we're correcting ventilation abnormalities is looking at CO2. And the most common one that I use as a clinician is how to adjust not only the tidal volume or frequency, which you can see the two spins on that, the known, the desired tidal volume, look at the known CO2 and the known tidal volume versus the desired divided by the desired PaCO2, and also the same frequencies, a similar calculation. But the one up above there, if you look, then just using your minute volume and adjusting your minute volume at that point, you really find that when you're managing a ventilator, that once we get our target tidal volume of 6 to 8 cc's per kilo of ideal body weight, we really don't adjust that tidal volume from there. If we need to adjust ventilation, we move the respiratory rate up and down, not the tidal volume, because we don't want to keep turning the tidal volume up and get into dangerous pips and plateau pressures and cause that would cause acute lung injury in our patients and put them into ARDS if they aren't already. So I calculate the known PaCO2 times by the known minute volume and divide that by the desired PaCO2, and that'll give us our desired minute volume. So that's what I like to do, and that's really a slick way to see what our target minute volume should do based off what our CO2 is doing. And granted, this is certainly in a patient that's not breathing on their own. If we do have a patient that's breathing on their own, they're eventually, if we support them and give them the breaths and the oxygen and what they need, and I should say the support, that they're going to regulate that on their own. So if we can sedate a patient, keep them comfortable, and let them breathe on their own, they're going to regulate that rate on their own, and your life is pretty easy. Where you really make this come into play is someone that's heavily sedated or has to be paralyzed, and we've got to breathe for them because they're not triggering the vent on their own. Then I really need to dial in what minute volume and what rate I need to set to make that happen, to keep their CO2 blown off. So if we have elevated CO2s and decreased pHs, then ventilation is adequate. And you can see, and through your other classes and so forth, the potential abnormalities that can cause respiratory acidosis. We also can have respiratory alkalosis, and we talked about a little bit about blood gas interpretation in one of the earlier weeks. But certainly meds and overventilating and anxiety and metabolic issues and things of that nature can cause that respiratory alkalosis. Metabolic issues, your DKA patients, loss of bicarb, lactic acidosis, which you see oftentimes in the ICU, toxins, things of that nature, and then the flip side, the metabolic alkalosis, acid loss in the urine. You can have contraction alkalosis, where we are dumping a lot of diuresing them a lot, so they're dumping a lot of urine out, and we get excessive bicarb there. Loss of gastric fluid and stomach acids, either to NG or the patient's vomiting, a lot of things of that nature. So those are some of the issues that we can be confronted with. And once we underline that underlying cause, then we can fix those disturbances with the ventilator, but also we might be able to add some meds or some bicarb or things of that nature to take care of it. Well, one strategy is that we could increase physiologic and mechanical dead space, and if we see an increase in physiologic dead space, usually the most common cause of that is things like pulmonary embolism or lower cardiac output, where we have gas flowing in and out of the airway, but we don't have blood flowing past there to make that exchange, and so therefore it doesn't make any exchange, and so we have increased dead space because that isn't making any interface at the alveolar level with blood. Normal dead space volume, which is, we call it VD to VT, is 0.2 to 0.4, and patients with this issue, it can be greater than 0.7. I had a bilateral pulmonary embolism patient that was a postcode in the field that we resuscitated, and this was the issue with her, is her lungs are full of pulmonary embolism. So she was really difficult to oxygenate and ventilate until those pulmonary embolisms started to get broken up with the heparin drip. So certainly those are issues that we can see and deal with. Metabolic and carbon dioxide issues can cause increased CO2 production. We see this a lot. The same patient, I was teaching my young RTs, my students that were with me, that we had her rate was dialed in and she was comfortable and looking good. And then she's been on the vent for several days, and we decided to start feeding her. So they introduced a feeding tube, and once we introduced that feeding tube, I told my students and my young RTs that were there with me, I said, she's going to start potentially burning those calories from that feed, and we're going to see increased CO2 production, and you're going to see her rate come up, and certainly several hours into those feeds, we did start see her respiratory rate come on, and we made that accounting for because of that increased CO2 production. So it's something you want to take into account and work with your dietary folks, because it's something to think about, especially in these long-term ventilators, when we're trying to wean them. And then our dietary folks will come and talk to me and say, hey, I'm going to change the feed to a higher kilocal per cc. Are you okay with that? And I'll say, yeah, they're ventilating okay. They'll be okay. Or I might tell them, hey, let's be careful, because we're having trouble weaning their vent parameters to try and get them off the ventilator. So things to keep in mind. You talked about permissive hypercapnia in your one of your past assignments. And so permissive hypercapnia, where we allow that CO2 to rise because we're protecting the lung, and typically we put the vent into pressure control, and we limit that to whatever pressure we feel safe, usually inspiratory pressure of 30 or so, and we don't want that pressure to go above that and cause damage to the lung. if that lung is stiff and that lung and we give too much pressure to that lung, we can damage it. So we limit that pressure, and if that lung's stiff, it's not going to allow a lot of tidal volume there. So we know we're underventilating that lung, and we're going to see those CO2s rise, and sometimes we have to do that to keep them oxygenating. So we can allow them to breathe on their own. Sometimes they'll administer some sodium bicarb, things of that nature. But if we have intracranial lesions or cardiovascular instability, things like that, or cardiac ischemia, that is some issues that would be contraindication of this. But sometimes you don't have that decision if those lungs are so stiff that we're trying to protect them. That permissive hypercapnia is going to happen whether we like it or not, because we can't destroy their lungs in the process and cause air leak. Airway clearance when we're managing a ventilator is suctioning, and we talk about shallow suctioning, which is just the length of the artificial airways, and then deep when we go beyond. And there's the opening and close suctioning technique. Being 2017, we really don't do the open suctioning technique again anymore. We have closed section suction devices, so we don't have to break that break that airway. We know that if we do break the airway, that we increase our chances for VAP. So we always are going to do that closed suctioning technique. Long ago, when I was first in the business, we had devices called a bow die, and we use it when we bronchoscope folks. That allows you to push a device and it seals around it, and then seals when you pull the device out. And so, you know, that's how we used to do it, is that bow die, or just unhook the vent, run the suction catheter down, and suction the patient. But like I say, now we have closed suction devices, such as this one. We've always called them Ballard because that's kind of the brown name. It's kind of calling a copy machine a Xerox, even though it might not be a Xerox brand. Ballard was kind of the leading company, and that's what we've always used at my facility. I think they've been sold a couple of times, and Ballard is now Halyard, but it's a closed suction device. And they work pretty darn good, and we like to rotate them out if they tear or get soiled or things of that nature. Up here you attach to your suction hose, and here we have the button that applies it. There's typically numbers up and down here, and so you see this gentleman here, we have the sheath that covers that, and numbers that tell us our depth, and so we can match the numbers with the ET tube and make sure we're not going too far beyond the end of the ET tube. This little device here and here, that's for instilling saline. We really don't lavage a whole lot. We shouldn't. The data shows us we're washing surfactant out of the lung and causing ARDS. So the only time we're really going to flush a lot of saline down there is if we have mucus plug and dry secretions, and at that point we should go to heated humidified circuit. So here you can see the interface that hooks up to the airway right there, and this gentleman here is hooked up there as well. And then we control our suction with the thumb button. So we pre-oxygenate if we can, silence the alarms, pass it down, verify the end of the catheter where it's going to be in relation to the ET tube, apply our suction and withdraw, and always keep a hand on that ET tube so that we don't extubate the patient. And I hope that you've had the opportunity to do that in your clinical time. So unstable patients, and this is talking about indication for closed suction catheter systems. Everybody's indicated for closed suction catheter systems nowadays. That's what we use. That's the standard of care, so we don't give them a VAP. And another nice device out nowadays is called the high-low. what this does for us is allows us to suction secretions right there, right off the top of the cuff. And so we put our suction catheter right there. The protocol that I wrote at my facility, negative 20 millimeters of mercury continuous, or 20 to 40 intermittent. And so we keep that hooked up and keep that clear. And we flush a little bit of air down there if we need to, if it's clogged up. And that helps keep us secretions off the ET tube to prevent ventilator-acquired ammonia. The nice thing about these is it does a pretty good job. There's some decent data that says that it helps, and perhaps these devices cost about 3 times to 4 times the price of a regular ET tube. But if we prevent a ventilator-acquired pneumonia with the device, it's well worth the money. This is just a whistle tip or flexible suction catheter. I'm sure you guys have seen these in your clinical sites. And we used to just introduce those down the ET tube as needed. Really, that's gone the way of the dodo bird. We don't use that anymore. So suction levels, 100, 120 or higher with adults, maximum of 150. Child 80 to 100, and infant 60 to 100. And our NICU kids, we run our suction 80 is usually our protocol. Kids around 80 to 100, like it says there, and we usually run adults around 140 in the unit I work in. We don't want to run too high because your suction device can attach itself to your airway. You can cause avulsions, etc., cause trauma, and really it's going to collapse your airway, kind of like you get the quote-unquote wind knocked out of you. A similar effect's going to happen when you apply that suction in a closed system. And so it's uncomfortable for your patient. So I always make sure I listen to my breath sounds. And before I apply suction, if the patient's kind of coughing, that's not necessarily an indication for suctioning unless you can see it or hear it. So kind of a rule of thumb to remember is take your airway size, times it by 3, and then divide that number by 2, and that gives you your approximate suction catheter size for the airway you're using. These come in all sizes. In our hospital I work in, we carry 6, 8, 10, 12, and 14 French suction catheters so that we can accommodate any size airway. Indications, they can't cough it up themselves. You can see it on the flow graphics. You can see the chatter. They're desatting. One of my patients today, the best way I could tell that she needed suctioning is she started to desat. Every time I'd clear that out of her ET tube, so that's how I was able to determine that she needs suctioning. Certainly if you see increased PIPs or a decrease striking acute change in tidal volume with pressure control. And you can actually see it. They're in distress, things of that nature. The patient starts vomiting. I'll throw some more air in the cuff to seal that off, and then apply suction to the airway and make sure that nothing dropped down into the airway. Contraindications, really there's no contraindications. If they need to be suctioned, they need to be suctioned. There's not really a time that we're going to say, we're not going to suction them. About the only time we think twice about it is if we've just administered surfactant in the NICU. And if that patient needs suctioning, we're going to suction them, but we try not to, so we can allow that surfactant to do its thing in the lungs and get forced down in the distal airways and help with that lung recruitment. So hazards and complications, you can cause them to be hypoxemic, you can cause trauma, you can cause atelectasis because you're collapsing stuff down. You can cause bradycardia, you can cause increased pressure because they're coughing. You can cause bleeding because you hit the carina and they're anticoagulated. You can cause dysrhythmias. I've got patients that almost always will so when we have those type of patients that do get hypotensive, or if they start coughing hard and get really agitated, get hypertensive, we make sure that we've notified nurses and everybody else that, hey, I'm going to suction. And the patients that do get hypotensive, I usually have the nurse come in, and if she needs to titrate the blood pressure meds, to counteract that, and so that we don't put them into shock and things of that nature. Saline in installation, like I said earlier, there's not evidence supports that it's beneficial. Certainly about the only time I did that is if I have dry secretions. So if I do have dried secretions, that might be a time that I might instill a little bit to help it flow and have the patient cough up. But I will say that, when I first started this business 15 years ago, it's kind of commonplace just to do it all the time. And we really don't do it unless less indicated, just because of the issues that we can cause. After we suction, we should certainly see improvement and make sure that we have improvement. Turn off our alarm silence so the alarms are active before we leave the room. So I usually am really big on listening to my breath sounds pre and post, and make sure that I hear improvement, and that everything gets better, and like the patient I had today, that the SpO2 improves post-suction, things of that nature. And so just make sure that after we suction that everything gets back to normal, or what you expect to be normal, before we walk out of the room. As far as administering treatments and aerosols, there's a couple of ways to make that happen with our patients. We want to make sure that based on our mode that we're in, that the patients can still trigger that breath and breathe on their own, if we're using a nebulizer that is generating flow to push that aerosolized med into the airway. A lot of times we have someone in spontaneous or in control. They won't be able to trigger that breath when they want to, because your flow triggering has been washed out by the additional flow from the nebulizer. So take that into account when you do that. Take into account where you should put that T-piece to put it in line. If you're pressure triggered, then it should be up by the Y. If it's flow triggered, it should be further away from the Y, as to not whisk that medication away to the expiratory side. If it's a MDI, make sure we have proper interface so we're not breaking the circuit for either ways to provide this treatment. And then when we provide that treatment, that we have the indications for it, and two, that we watch for any issues as we start that treatment i.e. they're not triggering the vent, or we're getting high pressures, or the vent's alarming. We got to make an accounting for that as we do that. Kind of the way to skirt around that with most vents is to go to a ultrasonic type nebulizer, and then we're not introducing extra flow into that circuit, so that the ventilator doesn't have a fit with high pips and high volumes and things of that nature. So those are some of the hazards and complications. We can also cause high heart rates and all those normal issues that we can have to the patient's heart rate if we have a beta stimulant going on. And you can see some of the complications there that I talked about. We're adding gas to that circuit, and the ventilator is given that breath, and it's not expecting a bunch of extra flow to come back, and so it alarms because it sees high pressure, it sees high volumes and things of that nature. So we need to make an accounting of that. We also use these on non-invasive devices, and we have the same issue. We did introduce additional flow. The patient can no longer trigger the device. We don't put it in the proper place. Make sure we're putting that treatment after the exhalation device, like on the BiPAP, or a lot of that medication is just going right out that whisper valve. So keep in mind that we need to make an accounting and be good clinicians where we place our aerosol generating device in line, that the patient still can trigger it, that they're tolerating it always, and that we assess really good before and after the treatment, as we should with any treatment, and that we expect the outcome that we're expecting, and if anything deviates from a normal outcome, that we either DC it or reassess and fix the issue. So depending on the physician, I have intensivists that are huge on MDIs, and I have them that order SVNs, and everybody needs to play in the sandbox nice together. It just depends on what your facility and what your protocols are. Make sure we always place those on the inspiratory limb, not on the expiratory side, or the patient's not going to see it. If there is an HME in line, that we have a HME that will allow you to adjust back and forth from HME mode to treatment mode, or put them on a heated circuit where we don't have that issue. But certainly the HME is going to collect most of that medication that's trying to get to your patient and not do them any good. And we don't like to break the circuit and take that HME in and out, so it's certainly things you want to take into account when you start this. So as you've certainly learned in your respiratory med, you know, the indications of bronchodilator therapy and why you would need to do that. Also, postural drainage and chest percussion are also things we can do on the ventilator, but it's limited. When you keep in mind you have a natural airway in line there, and if we start rolling those patients around, we can dislodge that airway, and so that's things we need to think about. When we help with bronchs, remember that we need to introduce a bronchoscope into our ventilator circuit. I always make a point to hold the ET tube during the procedure, and then I stand there and keep the vent quiet and keep 100% watch the monitors and make sure that my patient's happy. What often happens when you have a bronch going is the big screen's there and everybody's watching the airway, and everybody forgets we got a patient connected there. And so, you know, as much as I'd like to watch the procedure, oftentimes I want to make sure that I watch my patient, and I'm doing that. So there's your anatomy of bronchoscope. Hopefully in your clinical time you've had a chance to look at that. If we see stuff that are plugs that we can't get out, or we want to look at a lobe and get really specific sputum results, or we want to do a scrape and look at the pathology of cells down in the airway, those are all indications of a bronch. We can have contraindications of we have bleeding, or the patient's unstable, and if they get hypoxic, they're going to crash on us. Things of that nature can cause us for contraindications and should be considered by the physician. There are hazards to it. We can't do cause issues just as we can with suctioning, and cause arrhythmia and death. And most of the complications I see is when we do a bronch on a patient that doesn't have an airway, and they crump on us, and we end up having to intubate them during the bronchoscopy. So some physicians will sedate them, throw in an airway, do the bronch, and then pull everything back out, just so they have an airway during that. And then I have other physicians that will just go through the nose and do their thing. So when we as RT set up for those, we should have bite blocks, we have the scope, have suction hooked up, saline, stuff to collect samples, make sure the patient's monitored, and then everybody's wearing their PPE. This is a little bow die I was talking to you about how we interface that bronchoscope into the airway. And this has just kind of a membrane that you push through that seals around the device. Other things to think about when we have patients on the vent is their well-being and their sleep status and all these other things that come into play, and also transport. That we can have fluid balance issues. And if I have a critical patient, I need to be aware of their urine output and make sure that that's happening. If we are fluid positive, then I know I might need to elevate my PEEP to counteract the forthcoming pulmonary edema because of the high fluid on board and things of that nature, and what the fluid shifts are going to happen when they're in shock. So I need to be aware of that. We want them comfortable. We want them in a normal sleep cycle so that their transition back on the vent is back off the vent is quick. That we're safe for them. That we have our BVM always at the bedside. That everybody knows what the tube depth is and how to properly be safe when the patient rolls around. That we're present for that. That everything is hypersensitive for that patient. They're in a bad position. They're not feeling good. They have a breathing tube down their throat. They're restrained a lot of times. They can't talk. They can't communicate. So we need to really make sure that we can provide for them and be their advocate. And then when we transport, that we always take a way to bag them, that our transport ventilator is appropriate. We have appropriate settings, alarm settings before we go, and that vent's operating. You know, I've seen situations where I've had good RTs that have hooked the patient right up and didn't verify that the circuit was working properly and had the patient crash as they started down the hall to the CT scanner. So make sure that your device is working and that you have your bag with you, and all your stuff's ready to go before you leave that room, before you unhook them off your ventilator that's already working. Having worked air transport and flown patients on a Learjet intubated all over the country, I would always hook them up to my transport vent, and then I would just wait, even though the pilot and everybody wanted to go. I would say we're watching them for 10 minutes and making sure everything's good to go. And so you can certainly be that advocate for that patient and say we're not going anywhere till I'm certain that everything's jiving on the vent. So our last chapter here is improving oxygenation and managing ARDS. And so we have hypoxia and hypoxemia. I usually do a discussion post that talks about that we can be hypoxic without being hypoxemic. And there's different ways that we can do that, as they're outlined here as well. And that we can have circulatory hypoxia. We can be sat in 100%, but if it's not getting circulated around because of heart failure, things of that nature, we can still be hypoxic. So here's your regular normal levels that you should be aware of on this table. The 80 to 100 is the normal range for the MBRC hospital on your TMC exam. Now, me sitting in Utah right now, our normal range here, because we're at almost 5,000 feet of elevation, our normal range is 60 to 80. But for all your testing purposes, always make sure that you have that 80 to 100 as your normal range. And when we assess that, we assess the FiO2 and the saturation, We also look at the other things that are important on our blood gas, that we look at the hemoglobin to make sure that's normal, that our AA gradient's okay, that our PF ratio is appropriate. And I also do a post about that with looking at acute lung injury versus ARDS, and our PF ratio that's 100 or less is severe ARDS. So when we evaluate that in our patients, we obviously will have that continuous saturation monitor, and if our hemoglobin's good and we can trust that monitor because it's working and we have a good pleth and it's matching up with our heart rate, then we can put our trust in and take care of that patient. Those sick patients where the SpO2 is no longer working because they're clamped down peripherally because of their septic shock or whatever's going on, you know, if we can't monitor that, then we perhaps need to go to 100% just to make sure that they're taken care of. This equation that we talked about earlier about maximizing or optimizing our CO2, we can also do with our FiO2 with our desired PaO2 times our FiO2 divided by our known PaO2, and that'll give us our desired. Really, I don't use this equation as such. I use it mainly just for optimizing my CO2 and know what minute volume I need to get to, because we do have a reliable pulse oximeter and a couple of blood gases, and we know right where we need to be based off our hemoglobin. So if we need to increase our PaO2 and we're already, you know, high FiO2s, we need to adjust our mean airway pressures. So we have FiO2 we can adjust, we can turn up our PEEP to increase that pressure gradient and force that oxygen across. But the name of the game as RTs, especially in an ARDS patient, is we want to increase our mean airway pressure. We want that higher pressure throughout the average breath on that airway. And so ways that we can adjust that is one, yeah, we can turn up the PEEP. The other way is we can turn the rate down, and so that breath cycle is a little slower. The other thing we can do is turn down our inspiratory flow and allow that breath to come in slower if they'll tolerate it, or lower our I time. And then that means that we have higher pressure for a longer time on the airway to increase our oxygenation. And so here's a nice picture of all the factors of what mean airway pressure is the sum of all these pressures throughout the breath cycle. And that's how we write it, as PaW. And so a simple method for calculating that, but really the best way to look at it is to look at it on your ventilator and let your vent calculate that. And hopefully in real time we can do those things to improve our mean airway pressure and to increase our PaO2 to our patients and our saturations. So we do have shunting that can have, which is perfusion without ventilation, and we can have atelectasis, edema, pneumonia, pneumo, airway obstruction. All these things can cause that shunt. So just the other day, we had a patient that had refractory hypoxemia, and ended up being that we had just profound atelectasis. And once we started to get that patient to recruit, then everything started to get better. So think outside the box and think, is this a dead space issue, or is this a shunt issue, or is it both? We talked a little bit about on one of your assignments about inverse ratio ventilation. Inverse ratio ventilation is where we have a longer I time than a longer E time. And so we'll do this with patients to increase our mean airway pressure. And so in the olden days when I was a new RT, we'd have to paralyze these people because this is so it's not a normal feeling to have this happen to you, so we'd have to paralyze them and knock them out. But with new modern vents with active exhalation valves, now we can put patients in inverse ratio APRV, and these patients can have these long high times, and even when their lungs are full, they can still spontaneously breathe with full lungs, and it feels natural to them. We don't have to paralyze them. And that's nice because then they don't get profoundly weak. Like our ARDS patients used to get so weak that they would spend months on the vent as we tried to get them stronger again after we got them through that ARDS onslaught. And so everything's better now that we've done that. We have atelectasis, and that's something we're fighting on the ventilator all the time. One way that we know that we've hit our optimal PEEP is we're going to look at what is our critical opening pressure. Normal PEEP when we start on a vent is usually 3 to 5. We always start at 5 at my place, but usually therapeutic PEEP is anything above 5. Remember, when we turn up our PEEP too high, we can affect cardiac preload, and that blood can't get back to the thorax if it's too high, so we need to keep that in mind if we have a hypotensive patient. But if we have a stable patient as we start turning up that PEEP, let's optimize our PEEP, and how we're going to do that is find out where their critical opening pressure is on their FRC loop. And so as you can see that as we look at the different zones of the lung, that we can have atelectatic lung and a normal lung zone, and then an overinflated or overdistended lung. And that's quite common with ARDS patients. That's non-homologous lung. That we have good spots, normal spots, sick spots. And so we need to optimize our PEEP to keep those good alveoli open all the time, so they're not just open and closing all the time and having them get inflamed as well. So one way we can do that is we can look at our pressure volume loop. And if you look at the low or the lip, the low inflection pressure, that's when the alveoli open up and we get a big opening of pressure, excuse me, a big opening or increase of volume for not a lot of pressure change. So what we like to do is we'll do what's called a low flow inflection maneuver. We'll do a control breath on these patients and look and see what this loop does. And we know if we see where that low inflection point is, that we can set our PEEP at that point to keep those alveoli open. And then when we see that duck beak, or whatever you want to call it, as that pressure starts to trail higher with no increase in tidal volume, then we know that's our upper inflection point, and that's where we want to terminate our breath. And so that's how we look at that static pressure volume loop, and that's how we can set our sweet spot for where we want our PEEP to be in these ARDS patients. ARDS patients are challenges. We have, like I was saying earlier, good lung and bad lung, and it's kind of intertwined. And so the best way we found at this point is to establish this lower inflection point and don't overdistend that alveoli at the other inflection point. And that loop should look, I thought I put one in. I'll just draw it here. Let's get back to this picture here. What we want to create is, if this is our lower inflection, upper inflection, as this comes back, it should look something like that. We call it our FRC football. So this is our functional residual capacity that we want to maintain. And so we want to keep that at a nice angle so it's not trailing this way and it's not trailing super high. That's a nice angle like this, and that we're hitting our upper and lower inflection points. And that's the best way to prevent further lung injury. Keep your alveoli recruited and to maintain ventilation on these folks. ARDS patients are some of the toughest patients that you're going to ventilate, but also really rewarding when you get them through. Lung protective strategies. Remember on your MBRC exam and throughout school, it's 6 to 8 cc's per kilo ideal body weight. But if we're going lung protective strategy, 4 to 6 cc's per kilo, and make sure we keep our plateaus less than 30. You will see that on an MBRC exam. And we want that lowest PEEP required to keep those lungs open, but we also aren't going to be afraid of that PEEP if it's higher than what we're used to, because the data is showing us that it's the shearing and the dynamic forces, not that constant pressure on the lung, that's causing the injury. So ARDS is inflammatory. You get cell leaking, and that's how we're going to counteract that, because we're going to have pulmonary edema. We can have non-cardiogenic pulmonary edema, which is another definition of ARDS, or we can have cardiogenic pulmonary edema. Proper PEEP is the key to take care of that. And as I was mentioning, that pulmonary embolism patient I had last week post-code, she had massive flash pulmonary edema, and as I listened to her and kept the suction and I kept ramping up my PEEP, finally when I got to a PEEP of 12 on hers, that pulmonary edema went away, and I was able to let that anticoagulation therapy take over, and got her turned around, and she's extubated now and surprisingly doing well, which is great to see when someone's had their heart stopped from something like that. There are recruitment maneuvers. There are site techniques. We don't use a whole lot of that anymore. Recruitment maneuvers you might see on your TMC exam. I certainly saw it when I took the ACC exam, ACCS exam, but I haven't seen recruitment maneuvers sneaking into the TMC exam yet, but it certainly can. So I'm not going to spend a ton of time on that. We can once in a while put these patients into prone positioning, finding the sweet spot of the dependent lung. It's usually a last-ditch issue. We get facial edema and chance for pressure sores, and it's tough because we have all these other lines to deal with. But I have seen some good outcomes from it. We can also use independent lung ventilation, where we use a dual lumen or Carlin's ET tube, and we can ventilate our patients. The sick lung we can leave alone and just ventilate the good lung. So I go through pretty quick through that second chapter, because not so much of that is going to find its way onto your final and subsequent exams, but I did want to touch on some of the ARDS management. So again, if any of you have questions, let me know before you take your final. Make sure that you have the honor lock stuff in line, and that you have your area clear and you're not talking to anybody, and you won't have any issues with that. If you have questions about this or anything as you get ready for your final or your final assignments, let me know, and make sure you get all that stuff in time, since we're up against the end of the mod. Everything's going to close on that last evening, so I'll be getting grades ready to turn in, and so it's tough to accept any late work after the closing of the mod. So get all that done, and get your discussion posts in, and you should do great in the course. And appreciate your time and your hard work this mod. If there's anything I can do for you in the future, please let me know, even if you're not part of a mod I'm teaching. I'm always here for you in the business as an RT to help you get ahead or get you through your TMC or whatever you need. With that, thanks for your time. Again, let me know if I can do anything for you, and have a good last week, and good luck to you in the future.